Okay, hello everyone. Thank you so much for joining us on this Saturday. Welcome to Examining the Triple Pandemic, COVID-19, Interpersonal Violence, and Systemic Racism. My name is Gillian Cutshaw, and I'm one of the campus advocates with SAFER. My pronouns are she, her, hers, and I'm very excited to get a chance to chat with you all today.
Hi everyone, my name is Jennifer Macmartin. I use she, her pronouns, and I'm SAFER's prevention specialist for gender-based violence initiatives. Before we get started, we wanted to acknowledge the land on which Cal Poly sits, and that it carries the heritage and culture of the indigenous people of San Luis Obispo County, the Yak-Titu Yak-Tilhini Northern Chumash tribe. We honor the indigenous people's connection to these territories and respect the land on which we gather virtually today. If you are not currently located in San Luis Obispo County, we do encourage you to find out which native lands you're currently occupying at native-land.ca.
So this is a little bit of a glimpse of what we're going to be talking about. We're going to cover the services that SAFER provides, then dive into the triple pandemic, and go after that into talking about trauma-informed care and what that is, and what it looks like specifically in virtual environments, and finish up by providing you all with some resources.
Awesome. So for those of you who aren't aware, we'll give a brief snapshot of what SAFER does on campus. So SAFER is Cal Poly's primary confidential resource addressing all forms of gender and power-based violence. And so that includes sexual assault, dating and domestic violence, sex trafficking, sexual harassment, stalking, really anything under that broader umbrella. And we have two main branches of service. So we'll dive a little bit deeper into what those look like. But I oversee the prevention education arm, and really we operate under this assumption that violence is preventable, that these types of violence, sexual assault, domestic violence, stalking, etc., they don't have to be an inevitability of attending college, right, or existing as a human in this world. It is preventable, and we can create a space where violence is not the norm. But in order to do that, we really need to have everybody involved in this movement in some capacity. So every single person has a role, whether it's small day-to-day things or launching this into your career. There's a full spectrum within that of places that people can get involved. What we offer in prevention education are these individualized workshops across campus. I work really closely with some faculty and staff offering consultations to make their classroom environments more trauma-informed and prevention-focused. We're also beginning to offer some restorative options for Title IX cases, peer-to-peer education, and lots of different ways that students, faculty, and staff can get involved through education. And I will pass it over to Gillian to talk about what she does with advocacy.
Great, thank you. So yes, currently we have two confidential advocates. Even though we are remote, we're offering services and have been since the beginning of the pandemic. Students are able to connect with us, as actually our staff and faculty, for support around any type of gender and power-based violence that they may have experienced or that a loved one may have experienced. So we provide emotional support and crisis counseling, safety planning. We get survivors connected with campus accommodations, whether that might be academic, housing, et cetera. We provide accompaniment to Title IX and law enforcement appointments or investigations. We also can support students who might be going through other types of legal issues, go to medical appointments, forensic medical exams, things like that. While at this point, we are providing everything as much as we can over Zoom. It would really be a case-by-case basis of what we would be going in person to provide. We partner with RISE, which is San Luis Obispo County's Rape Crisis Center, to make sure that survivors are being supported all of the time, so 24 hours a day. To access our support, we have an online form, and you'll notice at the bottom right of the slide, there is a QR code, and that QR code should be found on every slide in this presentation, and that will take you to a page where you can make an online appointment with myself or with our other advocate, Sarah Wilson. And so that's a really easy way to get connected. You're always very welcome to email and call the SAFER office. I am there 2 days a week, but yeah, that form is probably the easiest way, and you can also find that on our website at safer.calpoly.edu. So we are also just one of two areas on campus that does provide that confidential support. I want to put that out there. It's SAFER advocates and counseling practitioners, so therapists, counselors within health and campus health and well-being. Okay. So, diving in a little bit now to this triple pandemic. Before we can get into any best practices around trauma informed care, we really have to understand the trauma environment that we're currently living in. So, we want to highlight the intense intersection that we see between public health epidemics and systemic oppression. So, it's really been quite a year in our world. Over the past year, we've seen a revival of the Black Lives Matter movement and people seeking justice for systemic and institutionalized racism. We've gone through an incredibly exhausting election season. We've seen an insurrection. We've seen the changing of the government from one party to another. We've seen the rise of far right extremist groups who support and promote white supremacy. And we're also 11 months into a worldwide pandemic, which is really something that none of us have seen in our lifetimes. Um, we also see intimate partner violence as an epidemic because of such extreme rates and the health consequences of experiencing this type of trauma. So looking at this Venn diagram, we're able to see how all of these intersect with each other. We're going to spend some time discussing each one of these topics and how they intersect with the other issues on the diagram. So I will start us out talking about COVID and intimate partner violence. So, but going as well, we're also going to be talking about the overlap here with isolation, the commonality of being alone and really forced into isolation. We're also going to cover after that systemic racism and COVID and the overlap of health disparities and the systemic racism and intimate partner violence component where there's an overlap of power and control and power differentials. So really, again, it's important that we're seeing and understanding exactly where we are in this moment. So yeah, let's look at this particular slide here, which is COVID and IPV. So how do these things interrelate with one another? Really, again, this is rooted in the isolation that everyone has been experiencing for such a long time. Whether or not we're survivors of violence, we're all isolated in some way because of COVID and public health guidelines. That does certainly seem to be improving, and I know there's light at the end of the tunnel, but we've still been largely in this space for a very long time and continue to be. So there's these extra complications in terms of domestic violence in COVID. In isolating at home, some folks have either moved back to a hometown or back even into their childhood homes to stay for the duration of this pandemic. Places that they're staying might be sites where abuse or trauma occurred as a child. And it also might not even be that they're going back into an actively violent situation, but they're being triggered by their environment based on things that they experienced when they were growing up in that space. Other folks might be back in hometowns where previously abusive or harassing ex-partners still live. I'm certainly supporting a number of students that have been experiencing this since the beginning of the pandemic, and it's very challenging. Other people might be sheltering in place with an abusive partner, and layers on top of that around accessing resources and having access to just be able to leave the house and be connected to the community. We also know from some of our students that they may have been here on campus and in that time found a community with other survivors, found a support network on campus, but they were forced to leave that support network because of COVID, or the other people in the network were forced to leave. So now maybe they're back in hometowns or living with parents or guardians who don't actually know what happened to them, and they're having to keep that quiet and shield that experience because they don't want to share that. So that can be really, really challenging for folks. It's also important to note that safety planning looks dramatically different in a situation like this. Safety planning is something that we as advocates generally do with survivors to help them make choices about their safety and what is going to be the safest possible route that they can take. It might look in sort of normal times like modifying the house that they're living in to be safer, or it might be making a plan to leave or attempting to leave a relationship. But that looks really different now than it did prior to the pandemic because folks just simply may not have resources to go to another place. People who are immunocompromised or high risk for COVID might not feel like they have the availability to enter a shelter. They may not be able to go to the home of friends or family because of COVID concerns. So there's this extra layer of public health crisis on top of seeking safety and support. I mentioned earlier, lack of access to support networks. So not being able to talk openly about the situation that's going on with them. I've had students leave their homes and talk to me in a car in a parking lot because they don't want their parents to overhear anything that they're saying. And then that concern that they have of having to time that right and having to make up an excuse to get out of the house and things along those lines. So not being able to freely access their support networks can really be challenging. Um, and again, going back to this idea of isolation. So when you're not able to connect to your support network, certainly that is extra challenging with this layer of isolation and separating someone from their community. If we're not able to make those social networks or reach out to community and seek resources, that's a significant barrier to seeking help. There's also right now a lack of financial support for shelters and support agencies because so many folks are experiencing their own financial hardship due to COVID. So as a result of that, there's less services available at a lot of the agencies that normally do provide services for survivors. Um, and again, more vulnerable populations have multiple layers of health risks. So survivors during this pandemic are less likely to seek healthcare as a result of being isolated by an abusive partner. So it's important to acknowledge how we really can't see any of these issues as separate from one another and that they're very much all interconnected.
Okay, so moving along into the next intersection and talking about systemic racism and COVID-19 and that overlap. And of course, the overlap there, the most striking one is the health disparities that come from both of these institutions. We know that the COVID-19 pandemic has disproportionately impacted communities of color in America, and racial and ethnic disparities in healthcare are already known factors contributing to higher morbidity, higher mortality among people of color as compared to white Americans. And so these disparities have a dual impact, right? So not only are they resulting in differences in the actual care and treatment that COVID-19 patients are receiving, but they also put BIPOC communities at higher risk of contracting COVID-19 in the first place. So the next information source is from Mental Health America, which has done some really wonderful research around the disparate impact. And some of the highlights are that that contribute to the damage affecting BIPOC communities include implicit bias in healthcare. So thinking about who is getting admitted into the hospital versus being sent home to rest and having more extreme consequences, right? Who's getting rushed into testing versus who's sitting around in the waiting room, who's put on the next ventilator, right? And so we think about all of these implicit biases showing up in the healthcare system. And even when you control for insurance status, income, age, condition severity, people of color over and over again tend to receive lower quality health care than white people do. In addition to that, there's potentially prior health conditions that people of color and those communities, they are 1.5 to 2 times more likely than white people to develop chronic health conditions. And these are often risk factors, of course, for increased COVID severity. And where do those, 1.5 to 2 times more likelihood for chronic health conditions come from? That comes from the intergenerational trauma of systemic racism, right? That has a really profound impact on our physical health. In terms of the long-term stress on immune system, this all comes from that complex trauma of racism and microaggressions, violence, police brutality. All of that chronic stress also weakens our immune systems in our biology. And so communities of color tend to have higher rates of COVID infections as well as more severe consequences of that infection. And there are also higher rates of being on the front line or being in essential service positions, right? There's a disproportionately high number of Black and Latinx workers that are unable to work from home, like a lot of us are. And those folks are overrepresented in the service industry and in social assistance industries. So there are higher unemployment rates due to those service industries shutting down. So I wanted to dive just a little bit more in depth into just a few communities to sort of spotlight these disparities. There are so many intersections to think about, of course, but I think pulling on these 4 communities really highlight a broader understanding of what's going on. A lot of these statistics were pulled in the fall of last year, just a couple of months ago, so it's important to think about how recent these numbers were pulled in this data set. So first, thinking about Black folks in the Black community, currently about 11.9% of employees in the United States are Black, but they make up 17% of frontline or essential workers. So that only further increases that disproportionality of high rates of COVID infection and death, right? There's also this first hired and last first fired, last hired phenomenon, whereas Black people tend to lose work earlier on than their white counterparts. And so therefore their unemployment rates are continuing to rise despite the employment market recovering for a lot of white folks. And thinking about the Latinx community, nearly half, about 49% of the Latinx population say that they or someone in their household has had to take a pay cut or has lost their job due to COVID-19. And that's in comparison to 33% of the broader US adult population. So half versus a third, right? That's a pretty striking disparity. The Latinx demographic in the United States largely works in essential and service jobs. And so due to COVID-19, these industries have either crashed, similar to like the hotel or the travel industry, which leads to lost jobs, or they're requiring people to be on those front lines and risk higher infection rates like hospitals and grocery stores. And adjusted for age, because COVID deaths rise with age, the mortality rate for Latinx folks is 2.5 times higher than white folks. Looking at the indigenous community and sort of highlighting that, the Navajo Nation has the highest infection rate of COVID-19 per capita in the US as compared to any individual state. And back in June of 2020, just last summer, the CDC was turning down request after request from tribal epidemiology centers for this COVID-19 data. It's the same data that is free to all of our other United States. And so without this data, these tribal authorities couldn't initiate any contact tracing on their lands or really impose informed lockdowns or other restrictions like other states were able to do. So just this lack of access to data and this gatekeeping from their own community, right? And so even though data shows that COVID-19 is hitting Indigenous communities hard, it's likely that those numbers are even worse than we know and worse that we see in the data. Many state health departments categorize Native American and Indigenous folks as other, suggesting that the severity of COVID-19 on those communities is severely underreported. And lastly, I wanted to highlight the Apida community, or Asian Pacific Islander and Desi American community. There have been documented racist physical and verbal attacks on Asian Pacific Islander folks since the start of the COVID-19 outbreaks, which has just been fueled by racist, xenophobic nicknames regarding about where the virus began, right? We see that Asian American businesses across the US began to report decreased business as early as January of last year, so over a year ago at this point. And many of those owners attribute that to misplaced fear about the origins of COVID-19 and how it's transmitted. So the increased racism and xenophobia are enough to cause this accumulated complex trauma in the body. We talked about earlier with that complex trauma really manifesting in our immune system, but it can also have a really devastating psychological impact, of course, for folks who are on the receiving end of this. And it's only exacerbated for those who have been physically or psychologically attacked due to their heritage. So like I mentioned earlier, there's so many intersections of identity with health disparities and COVID-19. These are just 4 of them, but I hope this just shows, how widespread this issue is and how we can't universalize the response to COVID-19 because it is broken down by so much supremacy and power differentials in our society. Moving on to the next intersection of systemic racism and intimate partner violence. The root cause for this, or the overlap, is in power and control, right? So with these cultural systemic structures we have in place where white people are at the top and people of color are pushed to the bottom into the margins, that's a power differential that's capitalized on, right, by the folks in power. And something pretty similar happens in intimate partner violence dynamics, where one partner has more control and power than the other, and they capitalize on that. So there's this sort of overlap in the dynamics of that on a macro and a micro level. In just a couple slides, we'll see this continuum of violence that shows that the roots of violence, whether it's sexual assault, domestic violence, stalking, anything like that, the root of that is really in power, control, and supremacy. And so you can see that these are really intricately tied together. We also know that communities of color tend to have higher rates of these types of violence than white communities and have a much different access to resource than white communities do. So for example, there are, of course, legal barriers in accessing trustworthy help from systems like law enforcement or other carceral systems. The lack of access to resources might be due to documentation status, to language barriers, class power differentials, things like that. Of course, that deep-seated systemic racism results in that micro-level lack of equitable care. When communities of color do go seek help, are they getting the best help that's out there, or are they being relegated to the margins yet again? There's also economic barriers to seeking services. And so thinking about if you're looking to, file a restraining order or to go to court and press criminal charges against your partner, you have to go to court during business hours, right? And so if you're working two full-time jobs, when are you going to have the time to go through that long, arduous, court process? You have to take the day off of work to file paperwork, et cetera. So there's just so much involved in seeking justice through this carceral state that a lot of communities of color feel like they don't have equitable access to. And of course, like I mentioned earlier, there's that direct health impact of trauma on these communities. So the intergenerational trauma that comes from systemic racism often can manifest in violence, right? This type of violence might be passed down as a result of the trauma instilled in the body. So there's so much more to say on this, and I will talk about this a little bit more in a couple of slides. But I really just want to hone in on the fact that we are here, right? We're at the intersection of every single one of these all at once right now today. And I think it's just really powerful to imagine all of ourselves at the center of this trauma, but also at the center of change making. That's where I find my hope, is utilizing privilege and my whiteness and leveraging, public health for COVID-19 and advocating for survivors, right? We all have a space in doing this work in some capacity. So we're here, right? We're here in the center where the systemic racism is historical. It's deeply embedded in our culture and our foundations as a country. We're here where COVID-19, as of today, I actually haven't updated this number, but I know that we're over 500,000 dead in the United States. We passed that milestone just a couple of days ago, which is just astounding, right? And we're also at this place where, according to the CDC, approximately 1 in 4 women, 1 in 7 men, and 1 in 2 trans and non-binary folks will experience intimate partner violence in their lifetime. So all of these are staggering statistics, and all of us are living at this intersection, and we have been for over a year. So we're talking about how these systems are all intersected, but their root cause is really this foundation of supremacy. So this is what I was mentioning earlier. At SAFER, we utilize this continuum of violence to conceptualize where violence specifically comes from in the first place. So we know that these extreme incidences of violence at the top of this pyramid don't just come out of the blue. They're cultivated and maintained by these foundations of supremacy and power differentials in our society. So you see at the bottom of the continuum are the roots that are so deeply embedded in our culture. Things like racism, sexism, homophobia, transphobia, cissexism, misogynoir, imperialism, classism, ableism, xenophobia, ageism, just to name a few. And when these things are considered to be the baseline of our cultural narrative, we start to move our threshold about what is deemed to be acceptable upwards, right? So since these roots of supremacy are considered normal and historicized in our culture, we begin to express these attitudes at the bottom without cultural backlash. So that might come in the form of gender roles, entitlement, locker room talk, objectification. So if those things culturally are given the green light and go unchecked, people will begin to push the envelope and verbally just express those degrading narratives, whether that's via harassment, microaggressions, threats, etc. And so if those things become normal at the verbal expression and degradation range, then it escalates to the point of physical harm, like sexual violence, physical assault, and even homicide. So you can see how these things don't just come from nowhere. They are bred and they are rooted in this systemic supremacy that we have. And that just plays out on the macro level and the interpersonal level. So what can we do about it? Thinking about the tiers of prevention, right? Because this can all feel really heavy and like a weight on our shoulders that we all can't do just ourselves. It takes a collective movement. And at SAFER, we use public health models of prevention to tie all of this together. So in public health prevention, there are sort of 3 tiers of strategies to do prevention work. Primary prevention would be something designed to prevent something from ever happening in the first place. Secondary would be sort of early interventions that decreases the prevalence of a specific problem you're looking at. And tertiary prevention is sort of after the fact. And that might be treatment like therapy or allowing people to heal after trauma has already occurred. And so I find it helpful to sort of look at these tiers of prevention in a lot of different lights to really grapple with what this looks like on the ground. And so I just wanted to quickly share some examples of what these tiers of prevention would look like in healthcare, with racist structures, and with violence prevention, just to sort of tie this all together. So in healthcare, primary prevention would be things like immunizations, mask wearing, and distancing when it comes to COVID-19, right? Secondary would be regular testing and contact tracing. So it's already there, but we're trying to mitigate it. And tertiary would be just healthcare for positive patients, right? It's out there. There's nothing you can do to prevent it at that point. They've contracted COVID. You have to take care of them. Thinking about systemic racism, primary prevention of that culture would be dismantling those power differentials and structures at the systemic level, right? Secondary prevention might look like affirmative action programs and trying to be kind of on the forefront of redistributing wealth and things like that. And tertiary prevention might be mental health support for communities of color, accessing options to report bias in the workplace, et cetera. And then looking at violence prevention, primary prevention would look like healthy relationship education, doing boundary work, talking about consent in an age-appropriate manner to children, right, and what you're allowed to do with your body. Secondary prevention might look like bystander intervention training, right? So it's already about to happen, but what do you do in the moment? And tertiary is survivor support. So I use all of these as an example to show like where all of us can get involved in some capacity. Every tier of prevention is necessary to get involved at, and we all have to sort of find our space, right? For Gillian's, for using Gillian as an example, right? She's in tertiary prevention of violence by doing critical survivor support, and we cannot let that go, right? Survivors need that support after the fact and need assistance in going to healing through all of these things. But we also, on the other hand, have to do primary prevention and educate about how to have healthy communicative relationships. So it's really this holistic approach to prevention that we need to take on. And, kind of our argument with this is that since the root cause of all of these disparities of healthcare inequity, systemic racism, and violence are these power differentials in our society, we need to engage ourselves in every tier of prevention we can in some capacity. That's sort of the call to action for today, is to find your space within that. We're going to go over some suggestions of kind of how to do that, some boots on the ground ideas. And I'm going to pass it over to Gillian to talk about what does this trauma even look like? How does it manifest in people? And how can we respond to create more equitable and healthier communities? So pass it on to Gillian from here.
Okay, so I want to talk about trauma and how trauma manifests and where it comes from. So offering trauma-informed environments really starts with understanding what trauma is. We know it can be defined a lot of different ways and really can be a response to a distressing or disturbing event or a series of events. Everyone reacts to trauma very differently. I think that's one of the key takeaways when talking about it, is it's not something that's easy to predict or any type of one size fits all approach. Some folks may experience acute stress disorder, which is relatively short term. Others may have full-fledged post-traumatic stress disorder or PTSD. Long-term effects with that, obviously, and it affects the person's ability to function on a day-to-day basis. We talk a little bit about big T and little t traumas sometimes in these kinds of discussions. Big T traumas are the ones that are usually extraordinary experiences that bring on severe distress and helplessness, such as a prolonged stressor like experiencing war or terrorism or abuse or neglect or systemic oppression. It can also be a one-time event or a long-term accumulating event. The flip of that would be small t traumas, and these are ones where somebody's bodily safety or life might not be threatened, but it's still something that's very stressful and traumatic and disrupts the normal functioning of their life in some way. A relationship event like a divorce or infidelity could be a little t trauma. Life stressors like financial troubles, work stress, legal battles, um, all of those types of examples. And folks might have an easier time recovering from a small t trauma, but they still do, in fact, need that recovery. So, again, we know trauma is really individualized, and any type of trauma can impact our way of life, our livelihood, our overall well being. And right now, in this time frame, so many of us are experiencing simultaneous small t and big T traumas. And some of those can relate to COVID, like job loss or financial hardship, prolonged isolation, juggling working from home with taking care of children at home. And many of us have also experienced being ill with COVID or having a loved one be ill or even pass away. Um, so, yes, while this is different for everyone, we've all been experiencing some kind of trauma for the past 11 months. Another big T trauma in this broader scale connection, or is this broader scale connection, sorry, to systemic oppression. Jen talked about this as well, touching on the idea of racialized trauma. I think is important to just note how, again, we all tend to think of trauma as a one-time life event, but it really can also be experiencing racism and microaggressions on a daily basis, and that can compound trauma. Racial trauma refers to the mental and emotional injury caused by encounters with racial bias and ethnic discrimination, racism, and hate crimes. It can come from other people or be experienced within a wider system. And it can be the result of a direct experience where racism is enacted on a person, or it can be vicarious, like seeing videos or seeing other people facing racism. And as Jen mentioned, it can be transmitted intergenerationally. She touched on the example of folks who are in the Asian community experiencing a significant increase in racism. Just to follow up on that example, we know there were nearly 1,500 reported incidents of anti-Asian racism in just 1 month following the COVID-19 outbreak. So we really are seeing a massive ramp up of that. And we know that for BIPOC folks, there may be multiple compounded traumas occurring simultaneously and exponentially increasing the impact of all of those traumas together. Touching on triggers. So triggers can be different for everybody depending on the trauma that they're attached to. Folks who experience systemic oppression might be triggered by certain language that's used, like a derogatory term against the community. For sexual assault survivors, it could be a scene in a TV show or a movie. It could even be something like a smell or a sound that could trigger that trauma response. And so it's important that we broaden our definition of trigger and what that can look like. And we know too, in addition to in addition to triggers being really omnipresent for a lot of folks, it's much more difficult to see and name those triggers when we're living in this virtual format. When we're in person, we're able to note changes in someone's body language or pick up on changes in their communication. But that's a lot harder to do when you're seeing people virtually, or you're really only texting or maybe talking on the phone occasionally. So it can be harder to pick up on when our loved ones or the people that we're working with or students are really experiencing triggers or having a much harder trauma. So that really brings us to talking about what we can do and what trauma-informed care is really all about. So we want to make sure that we clear up what this means and how do we translate that to the environments that we're cultivating and add this layer of being in a virtual space. So trauma-informed care has these 6 main pillars: safety, choice, collaboration, trust, empowerment, and intersectionality. These are the core tenets for operating with a trauma-informed lens. And really, I think a big part of being trauma-informed is shifting this focus from asking someone what's wrong with you to asking someone what happened to you, and understanding that having a cursory knowledge of where people are coming from is really important. Not assuming that you can tell what's going on with someone by looking at them, or that someone's poor behavior or withdrawn or affect or lack of participation is showing somehow that they're willfully being problematic, and instead understanding that it's very possible that they're dealing with some type of trauma in whatever way they possibly can. Um, we want to acknowledge that, yeah, it really can relate to behavior. And know some of the basic neurobiology of trauma and how trauma impacts the brain and the chemistry in our bodies. Um, PTSD results in neurochemical changes and in the way that we respond to things. So we have to know that for some folks, we might know that they're experiencing memory loss, or their memory might be out of order, or they might have a freeze response that lasts for a long time. They might not be able to talk about their experience or seem really closed off. And there might be a variety of coping mechanisms that they're engaging in order to navigate the response to the trauma that they're going through. So being trauma informed is acknowledging that we all have these variety of experiences, and that our behaviors to cope with them manifest in really different ways. So let's talk about these six core pillars and how to put them into an environment. So taking these tenets of trauma-informed care and incorporating them on a larger scale. So for safety, that's really things like providing routines and expectations for survivors of trauma. Having a routine and clear expectations is psychological safety for a lot of folks. Part of what is so complicated about trauma is that it can come unexpectedly. And so triggers can come out of nowhere, and violence is not predictable. So having that routine and expectation is very calming and helpful. If you're a faculty member, this might mean laying out guidelines and expectations around grading. If you're a community member engaging with people, that means having an agenda for what you're going to talk about so people know what they're getting themselves into. It could mean providing resources early on rather than at the end of a presentation. So that's something you'll notice that we like to do. When we presented today, we talked about who we are and what we do before we even started talking about violence. So giving folks that heads up, and also that resource ahead of time. So along the same lines as providing choice to people, part of experiencing gender and power-based violence or any type of trauma is that inherently your power and control, decision-making power and autonomy has been taken away. So as advocates and supporters and loved ones and community members, it's our job to put folks back in the driver's seat and give them full autonomy over what they choose to do moving forward. Offer options for folks so they feel like they have ownership over their participation. If you're a faculty member, offer multiple options for assignments. It allows people to really cultivate their own learning experience. In a virtual setting, offer different options for engagement and participation. This is really key because all of us are in this virtual environment so regularly. Don't require people to have their video cameras or their audio on. I know a lot of faculty require that for participation points, but consider actually not doing it. Some folks may not be living in a safe place, and having the camera on may be a safety risk. We want to make sure that we're offering as accessible of a community as possible, even over this virtual format. Offer to have students unmute and talk if they want, but give them the choice to use the chat box instead, or to message you privately so that they can show that they're engaged and that they're present, but they don't necessarily have to talk in front of everyone, or have that space where they're sharing something in a public setting that they might not feel comfortable with. So this way, folks don't have to out themselves or disclose to an entire group of people in a virtual meeting that they might be triggered or dealing with a trauma. And having those different levels of engagement does really help people to share when it feels comfortable for them. In terms of collaboration, that ties to community and providing options for discussion and debrief and feedback. Allowing students to create their own learning process, or community members to engage in their passion area, is allowing people to have autonomy and decision-making power, and to build community with other folks, which is really key. Trust, again, very important in all of this, providing transparency, humanity, and privacy. So showing up as a human being your authentic self, acknowledging that this is a really difficult time for everyone, and yourself included. So if we can share our experience with each other, that really does help build that community. Also remembering to take care of yourself first, because that is leading by example and being trauma informed and survivor centered. So we have to invest in our own self-care so that we can show up and be fully present for others. Part of trust is also, of course, acknowledging privacy. Privacy is crucial, particularly for survivors of violence. And this can be challenging in a virtual setup because it can make us feel like our narrative is on display. And it's also just harder to have a private conversation for some technological reasons. I worked with a student recently who was trying to have a private conversation with a faculty member regarding some academic accommodations that were in place following a trauma. And during the meeting, other students were just allowed to pop into the Zoom room. And the student I was working with found that to be incredibly difficult and really traumatizing. And it's just as simple as like creating a waiting room so that people don't just get to pop in to a session just because they have the link, or being mindful of, okay, other people are starting to be able to hear this conversation. Can we figure out a private time to talk, or can we go into a breakout room? Things along those lines. So if we're asking questions of someone also and they don't seem responsive, know that it might not be a good time to probe, and maybe it's not a safe time for them to disclose out loud. So be aware of our privacy limitations and be upfront with folks at the beginning of the conversation so that they know how they feel most comfortable engaging with us. Empowerment is a key piece. So giving survivors their power and control back, I mentioned that already. That means providing resources actively and passively. It means being able to connect with people where they are and ensure that they're able to make the decision of what they want to do moving forward. So getting them connected with resources is great, but not requiring or pressuring them to do any additional steps that they might not be comfortable with. And then lastly, intersectionality. So weaving an understanding of identities into all of our topic areas, no matter what we do in our community. Intersectionality and identity are a main focal point in the field. In SAFER, we work with folks across campus from a lot of different departments and different areas. And it might seem like there aren't natural connections, but at the same time, topics like consent, negotiating boundaries, responding to disclosures, trauma-informed care, supporting survivors, all of that comes up across the board, no matter what field or department someone might be in. All of this is related. So think about what your passion area is, what kind of work you do on campus or in the community, and how we can connect these survivors and really hone in on their experience around intersecting identity. So let's talk a little more about virtual environments. Now that we kind of have a bigger idea of what trauma-informed care can look like, let's look into some examples of making that virtual. So like I mentioned earlier on, we don't want to expect everyone to have their video or their audio on because it might not be safe for them. There could be a lot happening in homes that we're not able to disengage from as easily. And being trauma-informed looks like allowing folks to engage at whatever space feels comfortable for them and allowing for lots of different forms of engagement. Allowing folks to participate at different levels and giving them choice over how they do that is a wonderful thing. So if you're checking in with a student or a coworker or a friend, just give them different options of how they want to meet, what medium works best for them. Some people are really not comfortable with Zoom or FaceTime. So can you have an old-fashioned phone call, things along those lines. Giving people the choice to feel what's comfortable. Providing content warnings when needed is really helpful. Allow folks to opt in or out of discussions. Let them know what the topic area is going to be. If it's to do something like watch a video and comment or write a paper about a particular topic, and you know that that's going to be very sensitive, possibly offer an option. On social media, offer a note explaining what a post is going to be about so people can select to swipe through that rather than just be shown something traumatic or being triggered by something that they didn't consent to seeing. Remembering again, like we talked about, that triggers are different for everyone. So we can't possibly predict everybody's triggers, but we can provide a blanket statement around a topic area that we're talking about to allow people to self-select in or out. Acknowledge Zoom fatigue. Y'all, being on the computer all day is hard. I know you are resonating with that. I know that's real for all of us. This lifestyle can be really exhausting. And then compounding that with experiencing trauma, whether it's violence or oppression, can just make that so much heavier. So acknowledging that that's real and not, expecting people to attend extracurricular social engagements over Zoom, or understanding that people might just need to be sitting quietly with their camera off and in a room where they aren't having to look at the screen or really engage in that way, but they can still listen. Challenge by choice. That's a super helpful framework. It allows folks to participate in dialogues on their own terms. When you're working with students or doing a workshop or a dialogue, you don't actually have to call on people or force participation. And I know that that's tough. I've been certainly giving presentations a long time, and those awkward, quiet moments where you're asking folks a question and no one is answering do not feel great. And at the same time, try not to forcefully make someone answer something like, okay, I'm just going to call on someone now at random. If people don't want to talk, it's okay to allow that to happen and to offer alternatives. If you're finding that a dialogue is coming to an end or it's quiet, consider offering your audience the chance to send you a private message. That way you have a chance to address someone's concern, but you can do it in an anonymous way, or you can reflect or ask a question based on what somebody sent you privately. Being called out can be triggering, so just consider that as an alternative. We want everybody to have full autonomy over their narratives, and challenge by choice can really allow folks to engage in what makes sense for them. We also want to maintain a really acute awareness of any red flags in behavior. As I mentioned earlier, it's hard to notice behavioral changes in a virtual space. We aren't seeing the physical body language, the eye contact, the way that someone is showing up in person. So we have to have a heightened awareness around how they are showing up in a virtual space. Are they connecting as much as they used to? If you're a faculty member, try noticing if a student's missing assignments when they're usually pretty on top of it, and watch for a sign that something's off. Connect to ask if they want any support, if they need anything. We need to be more aware of these types of things so that we're able to check in with students and let them know that we're a valuable resource for them, and that we have additional resources and we can help them get connected and find what it is that they're really needing. So I want to check in on our time right now, and see if we want to maybe go forward and have a little bit of a breakout session. Jennifer and I have been talking a lot at y'all, and we appreciate giving you the opportunity to chat amongst yourselves a little bit. And so we're going to put you in breakout rooms for just a couple of minutes. We're going to put about 4 folks in a room. And really what we're just asking is, for your experience thus far in these past 11 months, what has worked or not worked for you in this virtual space? Have you seen anyone that you're working with, any of your faculty members, trying any of these more trauma-informed types of strategies? And if not, do you think that you could try to incorporate them or request that they be incorporated? So what has really worked or not worked for you all in a virtual space? Has anyone that you've been working with or anyone instructing you trying any of these types of strategies? And did any of them in particular stand out to you or feel really helpful? So Jennifer's going to put you all in some breakout rooms and just take a couple minutes to discuss what I just mentioned.
Jennifer, I think someone asked if you could put the slide of the strategies up again. Thank you.
Okay, I think we're all back. Does anyone want to share what they talked about in their breakout rooms?
I can start. Our group talked about how something that we're all struggling with is the fact that we can't really escape virtual. It's in our lives like 8 hours a day or more. And if you work from home, it's even worse too. And so it's just really hard to get up and move. I don't have access to a standing desk, although I'd like to, like options are very limited and you're kind of forced to follow the format.
Yeah, I was thinking recently about that adage that was going around early last year around like, we're not just working remotely, we're living at work, right? And that framework, oh, it just gets me every time. And thinking about like the disproportionate impact that that's having on communities is just striking. Yeah, thank you for sharing, Tara. Would anyone else like to share out?
We just kind of spoke about the importance of making it optional for people to share videos. And if the videos are being shown, you can even kind of connect. You can see if people look exhausted and just sort of give them that grace and check in too. Yeah.
I love that. Thank you, Katie.
So me and my partner shared different things. So one, my partner doesn't see it happening at school with their professors, but they are, I think, a paraprofessional, like helper at a school. And so they're going to work on implementing them themselves. And then for me, I actually work at a DVS agency in LA, and it's predominantly Asian and API focused. And so recently our racial justice committee had like a kind of debrief session of the hate crimes that have occurred. And our racial justice committee is open to our whole staff and those who are like wanting to be really involved, work on initiatives to bring our values in line with what we actually practice. And then other times we leave it open just to have discussions about current events or things that have been weighing on us.
I love that. Offering some open space for kind of that flow of communication. That's so important. Thank you for sharing. If anyone else has any other thoughts, feel free to pop them in the chat. I did want to make sure that we have a couple more minutes just to kind of close out and talk about the resources that are available to folks. Of course, this is pretty focused for San Luis Obispo, but we have some national resources on there as well. Of course, since we are a gender and power-based violence advocacy organization on campus, wanted to highlight some on and off campus resources for folks who are in the area. Of course, on campus, there's us and counseling services who are both confidential, but there are also resources to report if folks are interested in that route. Off campus, we have two really lovely nonprofits, Rise and Stand Strong, that do this work 24/7. We rely really heavily on them for the after hours and weekends. And nationally, there are sexual assault and domestic violence hotlines you can call 24/7 as well. And those typically will route you through to your local agency. So it makes it really accessible. Another one that I like to highlight is the crisis text line. It's not for gender and power-based violence specifically. It's really for any crisis or trauma event that you're experiencing. It's very easy to just text if you're not someone that likes to talk on the phone, myself included. It's a really simple way to get in contact with someone who's a certified crisis counselor to kind of walk you through some of the things we've been experiencing for the last year. So in terms of our contacts, I will let Gillian take this one on.
Yeah, so here's 4 different folks within SAFER that you're always welcome to connect with. Obviously, Jennifer up top is our prevention specialist. Ashley Hernandez is our project coordinator for the Department of Justice campus grant that we're working with. There's myself and Sarah, who are campus advocates. You can see we have a Calendly page, each one of us, so you're more than welcome to schedule an appointment that way. Or send us an email. We're always very, very happy to talk with you. And as for the advocates, while we aren't offering walk-in services right now, we will do our very best to make sure you're seen the day of, and if not the day of, then the next day. So Please feel free to reach out with anything that you might need support around or just have questions. If you have any questions, we'll stick around. So you can pop those in the chat. And we thank you all so much for your time with us today. It was really enjoyable.
Yeah, thank you. And I'm going to pass it back over to Ava.
Yeah, we just wanted to say thank you so much for coming, and thank you to our presenters, Jennifer and Gillian. I hope you all learned as much from them as I did. I really enjoyed this presentation. And then in the chat, I'm putting a giveaway and feedback form for the participants. If you could just fill that out, that would really help us guide, or that would help guide us like in how we plan this event next year. And yeah, thank you again for attending, and thank you to our hosts.
Thank you, everyone. Have a great rest of your Saturday.
Thank you all so much.